Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com. It's the 20th of October, and this is the RheumNow Week in Review. I'm coming to you this week from Dubai and APLAR 2017. The meeting just concluded. It was a full week from Monday to Friday of presentations. They had almost 2,000 people here. A really well-run meeting. I'll start with some information from this meeting. I attended many good lectures. Ian McGinnis was great. Johannes Bilsma was great. Michelle Petrie was great. I always like it when Munter Kamashta talks about antiphospholipid syndrome. He worked with Ron Asherson and many others in the field and is a leader in the field. He did a nice review, spoke of a registry of catastrophic antiphospholipid patients and really was able to shed light on the problem. What he did show was that amongst patients with antiphospholipid syndrome, only 0.8% will develop the catastrophic antiphospholipid syndrome, where there's organ system involvement, small vessel disease, and positive serologies to indicate the diagnosis. Many of the features that he talked about included that this tends to be a disease and a disorder that affects small vessels and skin, but likes to affect intra-abdominal organs, almost preferentially as highest on the list, pulmonary and the chest cavity being second most common. One of the big issues that he did cover was that many of these events are triggered by infections. It's not clear why that is, but they did present data that showed that it may be that there's molecular mimicry. Patients who did have infectious-induced catastrophic antiphospholipid syndrome often had evidence of peptides that were cross-reactive with beta-2 glycoprotein, and that sort of, again, fits in with the theory of molecular mimicry. Deaths are going down in the syndrome. This is a syndrome that has a high mortality rate, and it used to be it was 50%. It's now down to 37%, presumably with more effective diagnosis and treatment. So that's it for the catastrophic antiphospholipid syndrome. We had a lot of other news on the website this week. In a long-term study of RA patients followed for almost 7 years, it was shown that nearly 65% of patients were taking low-dose prednisone with an average dose of 3.1 milligrams per day, and that such patients, those that were on steroids, were more likely to have been on non-steroidals, DMARDs, biologics, have greater disease activity, higher CCP levels and CCP positivity, suggesting that this tends to be something seen in patients with more aggressive disease, and prednisone becomes one of several regimens that are employed in the management of such patients. News from the FDA last week was that, a few weeks ago, was that Sirukumab, an IL-6 inhibitor in development by Janssen, was turned down. They received a complete response letter. Janssen this week halted its IL-6 development program, citing the FDA rejection, the need for additional clinical evidence that really would make the development of the drug costly, expensive, and delayed, not necessary in the current environment. An interesting report in Annals of Rheumatic Disease talked about the use of abatacept, a pilot trial in those who have, want to make sure we're still going here, in those who had refractory disease. And it was shown that of those who received IV abatacept with either dermatomyositis or polymyositis, half of them were improved, and that when they did muscle biopsies, they did show the presence of FOXP3 T regulatory cells, suggesting a clinical and a biologic effect in such patients. A review of, this is a little older citation, but I put it up because I was covering psoriasis and psoriatic arthritis, found that psoriasis affects between 1.4 and 3.3% of the patients. It's estimated that nearly half the patients are not seeing an MD, and that nearly half the patients stopped their biologic therapy for safety or for no effect. Again, the incidence of psoriatic arthritis amongst patients with psoriasis has always been reported as being 5 to 40%, but there are there are consistent data now showing, multiple studies showing that the real rate seems to be about 30% of those who have psoriasis who will get psoriatic arthritis. A new report appeared this week in New England Journal about tofacitinib being effective in patients who have TNF inhibitor resistant psoriatic arthritis. This is a win for the drug. This is part of the data. This is the OPAL study that was presented to the FDA that led to unanimous vote suggesting approval to the FDA. It is likely this drug would be approved sometime before the end of the year. The data in this particular trial showed that response rates were 24% at 3 months for placebo, 5 milligram BID was 50%, and 10 milligrams BID was 47%. And the other primary endpoint was met with a significant decrease in HAQ-DI over time. An interesting report appeared yesterday in our RheumNow website that showed that rheumatologists are very slow to respond with DMARD changes to those who have manifest high or moderate disease activity. In a fairly large cohort, it was shown that the percentage of patients who had moderate to high disease activity, who had a change in their DMARDs, was only 60% after 90 days or 3 months. That the number went up a little bit more when you go out to 154 days, but again, there's a significant delay in the need for new therapy, the change in therapy. The time to achieve LDAS in these patients was 301 days. Again, very disappointing. So a paper that we have in press, myself, Jeff Curtis, a few others, looks at how we measure, and our study showed that more than half of rheumatologists do some sort of measure in their practice, with almost 30% doing a rapid 3, somewhere around 10 to 12% doing a Vectra. And, again, we measure, but obviously data like this says that we don't do anything with the measure. And this is disappointing, and there's this is a large unmet need in rheumatoid arthritis. There's also data this week about drug discontinuation rates and non-adherence in fibromyalgia. That may not come as a surprise to many of you, but 60% of patients were classified as being poorly adherent, meaning that they spent less than 20% of their days being covered by the medication that was prescribed. When they looked at the non-adherence rates, it ranged from 70 to 90% when looking at a lot of the drugs that we use in treating fibromyalgia, including SSRIs and tricyclic antidepressants. The number of people who are very adherent, with greater than 80% refills on their drugs, was only 9.3%. This is a major challenge. The last item on our news for this week is, for those of you going to San Diego, there is an outbreak of Hepatitis A in San Diego. There's been over 900 Hepatitis A reports, and so far 18 deaths associated with Hepatitis A in San Diego. A lot of these come from patients who are homeless, and patients, some of these are people who are in the food industry. If you haven't been vaccinated, it's about right now on the verge of being possibly efficacious, because the vaccination will require 2 to 4 weeks to have adequate immune responses to the vaccine. But this is an issue as we head our way to San Diego and the ACR 2017 meeting. That's it for RheumNow this week. Tune into the website for more news. We'll see you next week. Take care.